of CAR T, precision and versatile of the CAR T technology. Disclosures, I have no conflict of interest. First, let me talk about the technology of CAR T. CAR T, if we describe the technology, it involves mainly three parts. The design of CAR, target specific single chain or antibody or a ligand for the receptor. Second is gene delivery, because CAR is a genetic therapy technology. How to deliver CAR into cells is an important part. Third is T cell signaling. CAR Ts involve modification of T cells, T cells efficacy, memory, and safety. Our technology is mainly involving fourth generation with safety design of CAR, as shown in this graph. It has on and off switch, has several signaling domains for the CD3 T cells, as shown in this cartoon. The key to CAR T technology involves gene delivery, used to modify T cells. And we use lentiviral vectors to modify T cells. And in this cartoon, I showed you the second generation, third generation, and now in our design, fourth generation with safety design. The advantage of the 4S CAR is that it has a lower cytokine storm effect compared to second and third generation, so increase safety and maintain the same efficacy. The manufacture of our CAR T cells is shown in this cartoon. Apheresis is done first from patients, and the collected cells will be modified with lentiviral vector expressing CAR, and the T cell will be expanded for 2 days, safety examined, and ready to infuse into patients in 5 to 7 days. First, I will discuss the fourth generation CAR targeting CD19, mainly involve B-cell malignancies. There are new technologies, new novel technologies involved, and the special cases I would like to discuss. The transition from a last-line rescue tool using the CAR T to a frontline treatment options. That's where we are right now. The first case is many years ago. This is done in 2015, almost 8 years ago. It's a girl, 16-year-old, developed BALL with high risk, and her tumor burden in the peripheral blood is more than 90%. In the bone marrow is more than 98%. Conventional treatment all failed, and the doctors gave up on her treatment, and we started her on this emergency CAR T rescue. And we manufactured 1.6 times 10 to the 8 CAR T cells, only with 7% of CAR T positive cells. And after infusion, in 16 days, she achieved partial remission. And you can see that the flow cytometry analysis showed a very low level of CD19, CD22 positive blood cell. And in about a month of time, she achieved CR, complete remission. A second case example I'd like to discuss is for high risk, very end stage BALL child. And this child has BALL high risk, and the disease is a very high burden, and she has no T cell left, 100% leukemia in her bone marrow. How do we do CAR T to the rescue? And in this technology, we developed allo CAR T using her mother cell to manufacture CAR T, to then transition to auto CAR T in rescue. And this is published in Blood Advances and reported. And you can see that the cell first were collected from her mother, hyper-identical, and we manufacture allo CAR T. After infusion, she achieved almost complete remission in 2 months of time, in about 50 days. After 50 days, her immune cells recover gradually. We used her own cell to manufacture CAR T, so it's followed by auto CAR T, and she achieved complete remission in 77 days. And she received the allo transplantation from her mother, the same donor, after that, and she's in complete remission and live normal life right now. So from the example I gave you, that we can see that the fourth generation CAR T has very low toxicity even at a high tumor burden. And in hundreds of patients we've treated, most patients experience CRS, the cytokine storm, grade 0 to 1. Only very low percentage of patient has a higher CRS response. And even for patients with very high bone marrow tumor burdens, their CRS grade is very low. Therefore, this coins our technology. The 4S CAR T is very safe, has a low toxicity response. And the timing is the most important factor in the treatment using 4S CAR. We named the 4S CAR 2.0 as a second generation, on a second phase of this technology. And for high-risk leukemia patients, we follow next generation sequencing NGS MRD monitor to guide our CAR T therapy. So after induction, consolidation treatment, the patient will be assessed immediately whether to follow CAR 2.0 therapy or do intensified chemotherapy, and followed by NGS minimal residual disease monitoring, and to decide whether a transplantation should be followed or stop therapy off because achieved MRD negative state. And the example of using CAR T at the early time without involving HSCT is shown in this example. This is a 20-year-old female patient with a high-risk Philadelphia chromosome positive BCR-ABL P190 positive high-risk disease. She's enrolled in this NGS MRD 4S CAR 2.0 non-transplantation study. And after CAR T infusion, in her case, we can follow her CAR T kinetic. She received 3 CAR T infusions, multiple CAR T infusions, CD19 and CD19-22 double CAR T, and then followed by enhanced CD19 CAR T. As you can see, the kinetic shows expansion of CAR T in her peripheral blood for up to 2 years, and followed by next generation sequencing at sensitivity more than 10 to the 6 cells detection of blood cell, and she achieved MRD negative state for the 2 years, and she's in good quality of life. This is an example of opt out of doing hematopoietic transplantation, but just to use CAR T as early lines of treatment for the high-risk disease. So for the CAR T versus transplantation choice, early decisions can save lives, as we just showed you. Low risk is involving our CAR T treatment as a very low risk of a cytokine storm. At the reduced cost, so our technology has a very high efficiency and cost is relatively low, and the patient can obtain good quality of life with long-term remission. The next example I would like to describe to you the application of CAR T is in post-transplantation relapsed leukemia patient. CAR T can be another rescue at that stage. And we know for patients' risk stratification, if you follow NGS MRD, you can detect minimal residual disease by NGS, then the patient has a high risk of relapse, and the survival rate will reduce with time. With this monitoring, and they can guide us to the treatment timing for our 4S CAR 2.0 technology. This is an example of a Japanese patient. The first Japanese patient received CAR T is through our technology. She's a transplanted patient and developed for post-SCT relapse disease, and she received salvage chemotherapy, achieved MRD negative CR, then immediately followed by CAR T therapy in China. And she's maintained in CR for more than 6 years now without any maintenance therapy. And what we learned from this case is that she received the CAR T after achieving MRD negative CR from salvage chemotherapy. And based on MRD guided CAR T therapy, that we may be able to avoid a second transplantation in the high-risk group of patients. And this is a news report from Japanese newspaper. She's the first Japanese CAR T case under our treatment in 2016, about 8-9 years ago. The CAR 2.0 technology application in the post-transplantation relapse patient, we are submitting a paper for publication right now. What we have learned involves several factors, is that where the CAR T should come from, patient or donor, and what is the graft versus host disease risk, and what is the best timing, and whether the patient can opt for second transplantation. And how do we track post-CAR T minimal residual disease? If you have the tool for NGS, next generation sequencing, then you should use this new, more sensitive technology to track MRD. I'm going to switch to the next target involved not just leukemia, but B-cell lymphoma based on the Forest CAR 2.0 technology, experiencing the long-term follow-up and our current strategy. And we have been treating lymphoma patients for almost 10 years. This is an example of Burkitt's lymphoma back in 2014. After treatment for about 3-4 months, achieved complete remission. And in this B-cell lymphoma patient we treated with Forest CAR 19, she's in complete remission, continued remission for more than 6 years. However, after 6 years, she has a relapsed disease and turned out to be indolent follicular lymphoma. And this is from 2015 to 2023, almost more than 6 years after in complete remission. And she's in good condition right now after additional CAR T infusion targeting CD19. Therefore, even for long-term remission patient, the disease may still return. And the CAR T at that time can still be a tool, a very, very good quality treatment tool for this kind of patient. And we have treated many lymphoma patients in here. There are examples of diffuse large B-cell lymphoma, PMBCL, and CNS involved diffuse large B-cell lymphoma, and MALT lymphoma. And these are examples of double CAR T infused and expansion in the blood. And you can see that both CAR T expanded well in the patients. And in our statistics, we compare single versus double CAR T in B-cell lymphoma patients. As you can see that in the double CAR T cohorts, that the PR-CR rate is close to 90% in both diffuse large B-cell lymphoma and also in all lymphoma patients. This is based on our statistics. So the conclusion is that Forest CAR 2.0 can be very helpful. We can do sequential infusion of 2 or 3 target-specific CAR Ts. And the precision individualized medicine is key to this technology. Each patient is individualized, analyzed, and use the CAR T to fit their tumor profile. In the future, we will continue identify novel CAR T targets in combination with other immunotherapy strategies, such as PD-1 or PD-L1 antibody therapy, to overcome tumor escape. And I will give you a further extended example of CAR T applications targeting CD7 T-cell acute, CD7 positive T-cell acute leukemia. And like B-cell leukemia, T-cell is different lineage of immune cell that can also develop into leukemia. And most T-cell develop leukemia in the early stage, probe T or pre-T stage. And most of them are CD7 positive. Therefore, CD7 can be a good target. And there are about 20% of all cases of leukemia are involving T-cell leukemia. And the survival rate for 5 years is about 50%. And this is example of 3 leukemia patients treated with CD7 CAR T for their TALL. And you can see the kinetics of the CAR T expansion in all 3 patients expanded quite well. And one of the patients, you can see the temperature goes up and down during the treatment, and the cytokine response is obvious, a pattern similar to the CD19 CAR T. And the side effect is just rash and itchy response, and as shown involving here. Day 4, you see the rash developed. Day 14, you see rash. And all the 3 patients achieved complete remission in 2 months of time. So Forest CAR T is very effective in both T and B cell malignancies. However, achieve a long-term remission, there are still major obstacles. So in our technology, the new paradigm is we call Forest CAR 2.0. Now we involve multiple infusions, even at the time when the tumor burden was very low, and increased CAR T infusions can overcome the tumor burden and the relapse. The toxicity is low because of 4S CAR design, and T cell exhaustion can be overcome using multiple infusions. And we use multi-target CAR T to overcome antigen escape. So the Forest CAR 2.0 technology now we have shown have improved safety, effectiveness, and the very fast production time, and the cost we can maintain as low as possible. So the key to CAR success involved is early planning. The timing is everything. Timing is very important when the tumor burden is low and early in the stage of the disease. And the quality of CAR T preparation is important. High quality ensures a good success. And the last is not most important is the medical team's experience. The medical team need to be trained well to understand how to handle CAR T like another tool for this disease for the patients. Thank you very much for the attention, and I'll end my presentation now. This is our Shenzhen Genome Immune Medical Institute location in Shenzhen, China. Thank you.